Thanks, Rox. So I have pleasure to debate Sunil and Dr. Waxman, and these guys are experts in DCB and instant restenosis. So it's a big task here. So I'm going to talk about DCB as the treatment choice for ISR. So ISR is a problem, right? We all know that even new generations, we still have ISR rate of close to 10% in the first year, but drug-eluting stents, we still have issues. After a year, we still have incremental adverse effects at about 2% per year. And ISR is still 10% of procedures in the US. And these patients actually don't do very well. They have poor outcomes. So ISR, I'm just going to go over some of the reason why it is important is there's angiographic classification from Roxana, and then Dr. Waxman and his colleagues did the etiological thing. So you have to understand really why drug-eluting stents fail, whether it's mechanical, biological, mixed, or for whatever reason they fail. So I think you can understand that imaging becomes very important in these scenarios. And you can see, obviously, everybody knows de novo lesions versus restenosis. Restenosis people don't do very well. TLR and MACE is much higher in these patients. And we still treat about 82% of the patients, at least in the US, are treated with another layer of stent. Okay, so it's very important to know really the mechanism, and then we just go blindly put another stent in. And if you put another stent in, then the second intervention, obviously the TLR is much higher, the third intervention is even much higher. So the more the layers of stents, the more problems. And you can see as you put more stents, your vessel actually, the luminal compliance and reserve decreases significantly. So you can see 1 layer, 2 layer, and 3 layers. And this was a nice a study from Japan where they treated patients with DCB, and you can see after 1 year, your TLR rate. So look at the TLR rates, 14. 1 layer, 2nd layer, and after 3rd layer, it becomes around 40%. So the first layer DCB is attractive, 2nd layer DCB is also very attractive. So these are the trials, and I'm not going to go over it. I'm going to show you there's been so many trials, randomized trials with DES, plain balloon angioplasty, DCBs, plain balloon angioplasty, and then DCB and DES. So I'm going to go over 2 big trials, actually, ISA Desire 3, and then the randomized meta-analysis that I will show you a little later. So, but the reason I show you this red box is if you look at it, across the board, the TLR rate in all these ones are at least between 15 to 20% with both treatments. So these are the commercially or investigational DCBs that we have in the US. Actually, the agent is the first one that's been approved, and I'm going to go over that a little bit. So this is the trial, about 10 trials, randomized controlled trials of DCB alone versus DES, and you can see very large number of patients. And you'll see if you look at the endpoints on all these trials, there's actually a signal towards safety, which means that DES, first of all, is a problem, and we still have added events. But if you look at it over years, you actually have more stent thrombosis and maybe a signal towards death with drug-eluting stents versus DCB. The TLR rate actually was better with DCB. No, actually with DES. So you can see the TLR rate with Landmark analysis also was slightly better in patients who got DES versus DCB. But if you look at it, if you look at the analysis, the TLR is very different than your binary angiographic restenosis. So if your binary angiographic restenosis was 50%, you'll see the reintervention rate was 67% in the DCB, but only 50% in the DES. The reason is you don't want to put a 3rd layer of stents, right? So it was a non-blinded, it's biased. So that's the analysis for the TLR, but there was a signal towards safety. And there are other 2 trials. There's a small trial from China which also showed that long-term wise, there were safety issues. Okay, so this was the conclusion. So in BMS, bare metal in-stent restenosis, DCB and DES performed very, very well. The safety was the thing that was slight signal, and the DES I just showed you. This was actually recently published ISA-DESIRE 3 10-year follow-up. Plain balloon angioplasty, paclitaxel drug-coated balloon, paclitaxel first-generation stents, 10-year follow-up. And you can see over time, there was no difference in TLR between DCB and the stent, but over time, there was excess death. You can see cardiac death and all-cause death were significantly more so in the stent arm versus the DCB arm. So there's a signal here that tells you that all this data that shows you the DES actually has better TLR and maybe best to just put another stent in. Actually, none of these trials have been followed over a long period of time. And there is a signal that it keeps on going. So even if it's 2% per year for one stent, imagine what it happens with two stents. So there is a signal. That's why I think it's very important that these patients need to be followed. And then because of these trials in Europe, this is a class 1A indication for restenosis in Europe. And the reason why I was showing you the TLR rates, of 15 to 20% is because these are all done, most of them are done without imaging. And if you do imaging in in-stent restenosis, angio versus IVUS-guided, day and night difference across the board, along the same lines as all the imaging studies we've done. And these are two trials just came out recently. One is for the femoral popliteal artery in the legs, actually significant difference with the drug-coated balloon, IVUS versus non-IVUS. And then this was de novo, Ultimate 3 just published. This was de novo IVUS-guided versus non-IVUS-guided drug-eluting balloon, drug-coated balloon, and it actually showed significant difference. So imaging is important, but this is more important. So if you look at it, you got to learn to do it right. So image, if you have residual stenosis less than 20%, you correctly size it to about 91%, and then you do greater than 60-second inflation. Look at what the TLR is, single digits, right? So when you use imaging and you use these techniques to do drug-coated balloon, is even better than any of the drug-eluting stent data that you've seen. So agent was, I'm just going to go, everybody's familiar with it, this was just approved. And this trial is really to get a drug-coated balloon approved in the US, is because nobody really does balloon angioplasty versus a drug-eluting stent, right? But nevertheless, we needed to do this study. It was important, and you can see across the board, drug-coated balloon angioplasty versus agent, significant difference over time. TLR, no-brainer. So this is really, it wasn't standard of care that we do now, but it needed to be done, and stent thrombosis was better. So very, very important, really. So I'm going to show you my algorithm and why I think that this is Ron's thing, and he's going to debate me. This is his classification, but if you can see, if it's underexpanded, you cause injury, but you're going to expand this. Rotational, whatever you want to do, you want to expand it, but you still cause neointimal injury. So DCB. Stent fracture, two things. One, if it's fractured, metal comes and it keeps on going like this, you cause fibrointimal hyperplasia. Or you have stent fracture that actually has protrusion of tissue coming in. If it's protrusion of tissue, may not be drug-coated balloon, but the other one, drug-coated balloon for sure. And you can see drug-coated balloon, new atherosclerosis, drug-coated balloon in terms of new atherosclerosis with calcification, and then with greater than 2 layers of stents. Obviously, I showed you, and Ron is going to talk about brachytherapy here. So that's my thing on drug-coated balloon, and I believe that because of this long-term outcome and because of what I've shown, I think drug-coated balloon will become the choice. Thank you.
All right, well, that's good. Thank you. Thank you. Well.